I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the MedEd 101 Nursing Pharmacology Review course. All right, this will be the first section of diabetes. I'm not going to focus specifically yet on the pharmacotherapy, the pharmacology of medications specifically used to lower blood sugar, but I'm going to talk about some compelling indications, potential contraindications, and goals of therapy when obviously trying to decide what and when to use, and then what other kind of collateral damage results from diabetes. So that's where I'm going to start, and then in the next section I'll cover the pharmacotherapy. All right, diabetes monitoring. Let's start with that. Most non-pregnant patients will have a goal A1C of less than 7. There may be exceptions to that. We might try to get a little bit more aggressive. We might try to get a little less aggressive, maybe in geriatric end-of-life patients. But by and large, 7 is a good target for most patients to start with. If they're having hypoglycemia, we may get a little bit less aggressive. If we feel that we could make control a little bit tighter, that can be beneficial as well. So again, 7's a good place to start. I think that's a good thing to remember, and just recognize as risks of hypoglycemia go up, and potential quality of life issues, things like that, as patients age, we may get a little bit looser with that goal. Other important monitoring parameters. It's important to monitor renal function. That can definitely be damaged from diabetes. Eye diseases, diabetic retinopathy, for example, definitely an important monitoring parameter. As a nurse, working with these patients, making sure that they're getting labs checked, as well as regular eye exams. And then, of course, the feet are really, really important as well. So, we can have amputations and things of that nature on account of uncontrolled diabetes. So pay attention to that, monitor that, and you'll be putting your patients in a lot better spot. Kind of alluding to some of that monitoring, potential complications in patients who have diabetes. There's an increased risk for cardiovascular disease, neuropathy and nerve-type pain, nephropathy, that's the renal issues, retinopathy, that's the eye issues. A couple others, gastroparesis. So this is a slowing of the gut, basically, and patients can have symptoms like nausea and stuff like that. Amputation risk I alluded to, and then infection risk. So patients with uncontrolled diabetes specifically may be a little bit more at risk for infections and not being able to heal adequately. All right, some preventative medications you may see utilized in diabetes. So diabetes patients are at cardiovascular risk just naturally on their own. Statins, antihypertensives, and aspirin are all strong considerations, obviously based upon what we're looking at for goals for LDL lowering, goals for blood pressure, and goal preventative measures to help reduce the risk of heart attack and stroke. The majority of diabetics or diabetic patients with the latest guidelines based upon cardiovascular risk calculations will have a target goal blood pressure of less than 130/80. So usually that's what we're trying to shoot for. Again, there may be exceptions to that. We may try to get a little bit more aggressive if they tolerate that, maybe less than 120 systolic. We may get a little less aggressive if they're, closer to end of life, or they've got a, history of numerous falls, those type of things. ACE inhibitors or using an ARB, that'll be the first line therapy typically when we're talking about using antihypertensive medications. Calcium channel blockers like amlodipine, that's a consideration as a second line alternative. Aspirin, most patients will probably benefit from aspirin, particularly as they get older. Consider the risk with other medications. Maybe they have atrial fibrillation and they're already taking an anticoagulant. Okay, then that risk versus benefit calculation might lend towards not using aspirin because we're worried about increasing bleeding risk. Other things to think about: past history. Do they have bleeding episodes, nosebleeds, GI bleeds, intracranial bleeding? What kind of patient history does that patient have? There are some risk calculators that's probably above the level of this course, but just know they are out there to try to decide and help make that decision, or at least prompt a discussion with the patient. For most patients, the baby aspirin is okay, 81 milligrams once daily. Statin therapy, I did include a table here. Many patients with diabetes and cardiovascular risk factors will require high-intensity statin, and the two statins that are most commonly used that get us to that high intensity is atorvastatin and rosuvastatin. Hypertension, alluded to that already a little bit. ACE or ARB is going to be preferred. Again, it helps provide that renal protection. Calcium channel blockers are an option, and thiazides are as well. Diabetic neuropathy, typical treatment for that, we're going to utilize medication like gabapentin or pregabalin. We can look to SNRIs, so if you remember that class of drugs, that would be like venlafaxine and probably more commonly duloxetine. Duloxetine has significantly stronger evidence for its use in this. If we've got localized neuropathic pain, we may consider topical agents such as topical lidoderm, for example. Another potential alternative is tricyclic antidepressants. Remember, they have some norepinephrine and serotonin reuptake inhibitor action. So if SNRIs don't work, or they're not effective or intolerable, a low-dose tricyclic antidepressant may be considered as well. But keep in mind, those TCAs are very highly anticholinergic. Can cause confusion, dry eyes, dry mouth, constipation, urinary retention, and so on. So not the safest drugs in the world for sure. Gastroparesis, I alluded to that potential complication with diabetes. Again, can cause a lot of stomach upset, nausea for diabetes patients. I will caution you a little bit with this. If you got a patient that is really struggling with this, a medication like the GLP-1 agonist may exacerbate this. They kind of slow down the gut, is the way those medications work. So if you know somebody has this history and it's been really problematic, those GLP-1s may not be an ideal choice. But I'll potentially talk about that a little bit more, and GLP-1 specifically, coming up in the pharmacology section. Metoclopramide, remember this medication is a dopamine antagonist, but it can help with certain GI symptoms like gastroparesis and nausea. Keep in mind, if you've got a patient with movement disorders and Parkinson's disease specifically, it can worsen Parkinson's disease symptoms, so pay attention to that. Another potential alternative in the management of gastroparesis is erythromycin. This medication has a ton of drug interactions, so don't love that. Also don't love the fact that it's an antibiotic, so you may increase the risk for antibiotic resistance if you're using this medication quite a bit of the time. In addition to the GLP-1 slowing the gut down a little bit, and any medication with anticholinergic activity can worsen gastroparesis as well. It'll slow the gut down further too. All right, important changes that can impact diabetes. I've got a couple of medications to really pay attention to. Corticosteroids like prednisone, a burst of prednisone for rheumatoid arthritis or asthma or whatever the case may be, it can spike blood sugars significantly, up 50, 100 points. So pay attention to that. If you have a patient reporting that they've been well controlled and now their blood pressures are spiking like crazy, always go take a peek at that medication list. Definitely could be caused by corticosteroids. I've seen that a ton in my real life practice for sure. Beta blockers tend to mask hypoglycemia a little bit. So if you've got a patient on insulin or any medications that stimulate the release of insulin, that would be classically a sulfonylurea, which I'll talk about coming up here. Beta blockers may mask some of the symptoms of hypoglycemia. One that remains intact, and that's frequently a pharmacology and board exam question, is sweating. Beta blockers do not affect the sweating symptom of hypoglycememia. Other potential changes that can impact diabetes and blood sugars, infections, stress. So those things can definitely cause blood sugars to go up potentially. Infection can also change appetite, the way the patient's eating, and that sort of thing too, which can obviously alter blood sugars as well. Dementia is something I've seen complicate diabetes care, where now the patient either forgets to eat, so they're losing weight and those type of things. I've also had patients that continue to eat. They don't recognize or realize that they're full or that they've just eaten. And, now they're gaining weight and their blood sugars are way up because, they're eating all the time. So pay attention to that for sure. Dementia can really change diabetes care up a little bit. And it's a good reminder to notify the providers if you see some changes in dementia that are altering appetite. It could definitely alter those blood sugars as well. And then any medications that suppress or stimulate appetite. I think of stimulants first and foremost. So medications that are most often used for ADHD, like methylphenidate and amphetamine derivatives. These meds tend to suppress appetite. And, if we've got somebody with an A1C of 6 or 5.8 and, we're giving them diabetes medications and now we start a stimulant and now their appetite drops, that's a situation where we're probably going to run into some hypoglycemia or at least at risk for it. So pay attention to that. On the flip side, probably the biggest medication that comes to mind is mirtazapine. Is an antidepressant that can often stimulate appetite. Got to be a little bit careful with that weight gain and obviously blood sugars going up for that reason. Treatment of hypoglycemia. This is definitely important to know. Glucagon. This is a medication that can be given if alertness is compromised. So typically what we're going to do is sugar replacement. If patients get, blood sugar less than 70, for example, if they're, clearly conscious, clearly with it, they can take medications orally or take, sugar replacement orally. We're going to typically do it that way. But if you've got a patient where that alertness is compromised and now we try to, put things into their mouth, they certainly could, choke and aspirate. So that's a big deal. Definitely an important thing for nurses to recognize. Glucagon indications, typically if that alertness is compromised, blood sugar less than 54. And we do have a couple different options now. Historically, it was just glucagon injection. But we do actually have a nasal option now as well. So that's definitely a good thing to remember. One last clinical quirk, Pearl with glucagon. you still need to give sugar. So hopefully you give glucagon, their alertness starts coming back, they're with it, they're coherent, they're able to do some oral intake, for example. We do need to get them some sugar to get that blood sugar up. If they aren't coming to, obviously this is an emergency type situation. We're going to get IV sugar going and make sure we get that blood sugar up for sure. Struggling with nursing pharmacology? Would you like a resource you can put in your hands? You're not alone. If you want to understand medications instead of just memorizing them, check out the MedEd 101 Guide to Nursing Pharmacology on Amazon. Written by a board-certified clinical pharmacist, this book breaks down high-yield drug concepts, clinical pearls, and real-world examples that actually stick. Perfect for exams and the bedside. Whether you're in nursing school or already practicing, this guide helps you build confidence with medications fast. You can find a direct link to the 233-page book right now at meded101.com/nurse. That's meded101.com/nurse.